Thank you so much for joining us. As you get settled into your seats to enjoy your delicious lunch, I wanted to get our keynote started, our lunch keynote. So we have a very special and exciting lunch keynote with Judy Mohr Peterson, who you all know as the Division Administrator of MedQuest, as well as Kate Sapra, who serves as the Director of the Division of All Payer Models for the Center of Medicare and Medicaid Services. So please help me welcome them to the stage. Thank you.
How cruel is that? Make you listen to us while you're eating lunch. You're a captive audience. But the great thing is all of the fantastic, wonderful things that we have to share today. So when they asked, hey, would you be willing to talk about Medicaid and maybe you could talk about your waiver and all these different things. At the time, we did not know, by the way, we can't see anything here. So we did not know what was going to happen. All right. Oh, that is, and there we go. But we can't see anything here in the front, so we don't know where we are. But, okay. All right, we will move along here. So we are here, Kate and I are here to talk about what's going on with Quest and MedQuest. And we have a lot of, all right, so one of the first things that we want to talk about is why is Medicaid focused, thank you. Now we can see what's going on, so I have to do this the whole time. So we're so excited to be able to be here and present with you today. One of the first things I wanted just to outline for folks, actually I'm going to stand up, that I really wanted to folks to adapt to or show, et cetera, is why are we even bothering talking about changing the healthcare system? Why does it matter? And it matters because we have a very fragmented healthcare system that pays attention to body parts in a very fragmented way. All our providers are divided up that way. We talk about cardiologists, and that's great. We want people to specialize, et cetera. But we forget that all those body parts are a person, and that person lives in a community with a family and school and work, et cetera, and that whole context. And then the other reason is if you're looking at this system, if you have something wrong with your body part, or multiple body parts, then we ask you to navigate the graph on the right on your own with no medical background or history. So we have a very, very fragmented, complicated system. The sicker you are, the more difficult it is to navigate. And it is the most expensive care in the world with not the best outcomes. So we pay a lot for a complicated system that is very, very difficult to navigate. So for that reason, we really want to focus, and this is us, this is Quest. These are the people that we serve. The pictures are our members and the people that we serve. And we are about quality care, universal access, efficient utilization. We want to stabilize costs and transform healthcare. And really, our vision is that the people of Hawaii embrace health and wellness, that everybody thrives. How do we do that? We want to focus on whole person health. We want to think about healthy families and healthy communities. We want to think about not just that body part. We want to think about you as an individual, in your family, and in your community. In order to do that, we want to make sure that people have access to care, that we focus and invest in primary care and preventive services. That's our long-term investment strategy with a particular focus on young children and their families. And we actually also want to invest in care for people with complex care needs. That's our short-term investment strategy. We know that if we do those things, in the long run, we will have a healthier, happier community and families. And we also know that we will save money. And with that money, we can invest it in other things. And finally, we want to make sure that we're paying for that health care and all that care, and we want to make sure that we're aligning our financial incentives. So what has Quest been doing in order to accomplish that? So in this last year, we renewed the eligibility. We restarted our eligibility processes for the Medicaid program that had been paused for 3 years of close to 500,000 people in our state in 1 year. So, woohoo, I heard that, yes. And you have to do that in order to make sure that people continue to have access to care. And so this is what our graph looks like. So we were going along and in 2019 and things were just, pretty stable, right? 2020, 328,000 people, 3 short years, went up to 468,000. That's about a 48% increase. Increases in the per capita. We're one of the top 5 states in the country for the proportional change that we had and the number of people that we were covering. If you think about it, it makes sense, right? If you're thinking about the impact of the pandemic, we went from having the lowest unemployment rate to within a month, the highest, some of the highest unemployment rates. And a lot of our people are employed and have employer-sponsored health insurance because of the Prepaid Health Act. So when people lose their jobs, they don't have health insurance, and we, as Medicaid, are there to help make sure that people have access to coverage. So now that we're through the unwinding, that's what it's called, unwinding, we're still close to 25% above what we were. And it's been that way for the past several months. We aren't seeing a big ups, nor are we seeing more drops. So we're much higher. We're continuing to cover a lot more people than what we were. The impact is not the same on all the different islands. There's different geographic impacts. So some of the largest increases were actually on Maui, proportionately, and have some of the least decreases. Obviously, from a population, Oahu has the most because that's where the majority of people live. The other thing that we've accomplished through a lot of work and assistance from many of you in the room is that's actually also continues to be making sure and helping to make sure that people can get access to care is we've done a lot of focus on our rates, on Medicaid rates. So we, as you heard this morning from the governor, we did increase our medical professional rates up to, we increased our medical professional rates for like doctor visits and things like that, up to 100% of Medicare. And we have a budget ask to continue that for this upcoming legislative session. We increased and changed our payment methodology for nursing facilities. The legislature included and we increased our rates for applied behavioral analysis, which is a type of treatment for children with autism. We also increased various different of our rates for home and community-based services, especially for alternative community residential settings, which helps keep people out of nursing facilities and living within the community. Just at the beginning of January, we expanded our hospital rates up to, well, if you include the pay for performance, it's going up to about 150% of Medicare. So that was a lot of work, and we're really happy that we are able to do that as well. And we've actually made some major changes in our policies regarding APRNs. So all of those things taken together really help the system, help the overall healthcare system, help maintain and make sure that we can continue with access. This is a really big one here. So this past year, when we're thinking about trying to improve care and help care for people with complex health needs, one thing that we did, and this is after a couple years worth of work, believe it or not, a couple of years worth of work, we became the first Medicaid program in the country, yes, to provide community palliative care as a benefit. So I know many of you in the room, you were with us working on this, and we just issued our guidance memo. It makes it sound like it's a 1 or 2 pager, but I believe it was close to 40 pages worth of guidance. And interestingly enough, I was talking to somebody and they were like going, yes, we still have lots of questions. And I'm like going, people, we were the first. Of course we're gonna have questions, but let's just go. Let's try to do what we can do to get this implemented. But what a godsend and what a blessing it is to be able to really put these services in place that fill that important gap for people. They don't need hospice or they don't want hospice. It's not a chronic disease they're facing, or maybe it is. They and their families are facing a serious disease, and this is that support that can surround them to help them navigate the serious condition. And then this is the crown here. So yes, yeah. I'm going to talk a lot more about what the details are. And just this morning, if you're listening to NPR, it was announced in the news today. And this took so much work, and people said, "Oh, it's lucky that it came in, before the change of administration." I said, that was not luck. That was a lot of work, and it was we purposefully, worked very, very hard to make it happen so that we could get the approval before, before too late, before the change of administration. We didn't want any kind of disruption that would cause us to have difficulty there. It's a 5-year renewal, so it goes from January 8th to December 31st of 2029. So super excited. Oh, yes, there we go. A little animation for us. But here's a little bit about what's included. So currently, our current waiver, our current waiver includes the new stuff, but prior to the waiver before the renewal, we already had Medicaid managed care, we had behavioral health in there, we had home and community-based services, as well as the beginning of some of our housing supports. But the new stuff that we've been able to include is really quite astonishing, with a huge focus on health-related social needs. Some of you are like going, health-related social needs, what are those? If I say social determinants or social drivers of health, maybe that makes a lot more sense. It's the terminology that CMS uses. They call it health-related social needs. So, and this includes a broad range of various different things. We're excited about the opportunity to provide nutrition supports. Many of our community health centers really discovered, it really emerged during the pandemic about what a great need that was for our community. And so this allows us to provide a lot of expanded nutrition supports, to provide what we call community integration services, and you see the plus there. Those are our housing supports, that strong connection between health and housing. So this is for, you heard the governor talk this morning about the kahales. So this is an example of what Medicaid can do, and that we can provide short-term transitional rental assistance. We can provide short-term utility assistance as well, along with some of the wraparound permanent supported housing services. So this is probably one of the bigger changes that we've been able to do and put in place. It also includes medical respite services for individuals. So if you think about an individual who, they're on the streets and they need to go in for preventive procedures like a colonoscopy, like where are they going to be able to do that? Like, I've done that. I would not want to be on the street and doing that prep. That's horrible. So this allows for housing for the pre-procedure and post-hospitalization. So we are absolutely thrilled that we had that. We also have expansion for our kids, for eligibility. We have continuous coverage for our keiki 0 to 6. Continuous coverage. Yes. And then 2-year coverage, 2 years of coverage, 6 to 19. So it's really, really amazing. And then the last thing I have up here on this slide is the justice-involved population. So this is the reentry services. Medicaid isn't allowed to cover people while they're in the prison, except under pretty extraordinary circumstances. And we are now able to provide services 90 days pre-release, a limited set, but things like 30 days of medication, durable medical equipment, case management. The individuals are going to be able to be connected with their healthcare provider, with their health plan, so that they have the care, and it's not an extra step. They don't have to take anything extra. They'll be eligible for Medicaid from the day that they're released. Actually, from before they're released. So we are absolutely thrilled about each and every one of those things. So if you read in the top paragraph there, it says fine print, has many guidelines. Do you remember those pharmaceutical ads, this great, wonderful drug that's gonna solve all your problems? Okay, and then they have somebody read that super fast. This might kill you. This will do these things, this will do that. So this won't kill you, but believe me, CMS, if they're gonna give you these kinds of flexibilities in your ability to do it, they wanna make sure that they know everything, and all the guardrails and all the protections. I think we have 4 times the reporting that we used to have, and there's this limit and that limit. You can do this, you can't do that. So there'll be a lot more to come out on all of this thing. And so, but for now, this is what we're going to be doing. We're going to be pausing. We're going to be taking deep breaths. We did it. And we're going to express gratitude, reset, and then go. But on that point of gratitude, when we were trying to get this through, by this January 8th date, CMS told us, okay, we're really, really sorry, but we're going to be sending you your special terms and conditions on December 23rd, and you have until December 30th to send it back to us. And it's 200 pages worth of single-space materials. And you have to tell us if there's anything wrong in there, otherwise we can't fix it. And it's like, oh, a week. So I want my team who worked on this. We have a lot of MedQuest. This is like, oh yay, we get to go to health policy. So I have a lot of people, this is a great event. I have a lot of people from MedQuest here today. I want you all to stand up. If you from the MedQuest team, please stand up. Anybody who worked on the waiver from the MedQuest team, please stand up. These people are the reason that we have the waiver approved. All right, now, all the rest of you, if anybody worked with us on palliative care, on the waiver, on any of those things, I'd like you to stand up also. Nobody worked on the rate increases? All right. That is, we, MedQuest, can't do this work without you. You are the reason, and our members are the reason that we do this work to make this difference. It won't all happen at once. It's not from day one. This will take a phased approach. But we are super, super excited about the opportunity to take this on. But there's more. Because none of this can happen unless we start to think about how it is that we need to change how we pay for these things and pay for these services in order to make this be sustainable over the long run. And so for that, I'm actually going to turn this over to Kate Sapra here to talk about our involvement with the HEAD model and how that's our opportunity to really transform and align those financial incentives.
Okay, Judy probably told me I was going to deliver these slides, but it feels like a surprise. In fairness, I have seen them. For those of you I haven't met, and I've had a chance to meet so many of you over the past 2 days, and looking forward to connecting with many more of you, I am so delighted to represent CMS here today. I particularly want to thank Joy Suarez from MedQuest, who made this all happen. Yes, organizing a site visit from CMS is a huge amount of work, especially since we also gave her like 2 weeks notice, but I'm really, really glad to be here, and I think my presence shows how committed CMS is to our partnership with Hawaii. I'm incredibly proud that Hawaii is one of only 6 states that signed up for this really ambitious program. Yes, that deserves applause too, and I know it took a lot of people to write that grant application. And again, MedQuest team, because MedQuest team does it all, but also the folks from SHPTA I see in the room too helped to write that application, and I know there was input from many others in the room as well, and it's that type of effort that we'll have to continue. I think that's what Judy was previewing is, no good deed goes unpunished. So if you helped us get this far, you can count on the folks in Hawaii asking you to continue to serve your community by being that voice and helping to drive change. As noted, Hawaii got their cooperative agreement, which is our fancy name for a grant. Yeah, I know. I just riff. Yeah, I've not prepared any PowerPoints for any of my meetings, so if you think you're meeting with me and getting a PowerPoint, like readjust your expectations. I'm really here to talk with all of you. But just in August, Hawaii received their funding and is in a 2.5-year planning phase that continues through this year and next year. Okay, and I wasn't paying attention when I was taught how to advance. There we go. So hopefully many of you know what the AHEAD grant is, and if you didn't, maybe Governor Green's remarks of this morning had you Googling, but if you don't know, it has a really long name, but I think each part of it is important. We really start with states, and it's states advancing this work, and that's highlighted here as well in the bottom right orange box, accelerating existing state innovations. For me, this is the hallmark of the model. CMS, Medicare, is here to be the wind in your sails. We don't want to disrupt any good work that's happening in Hawaii because there's a lot of it. Not just in Medicaid, though Medicaid is definitely a leader, as we've heard. And I was really shocked to hear it's 1 in 3 people in Hawaii that have Medicaid coverage, which, again, I think is a huge testament to the work that MedQuest does to have that level of coverage. But, you know, it's everyone in this room. There are many payers in the room, providers as well. It's really going to take all of us, and we don't want to disrupt any of the good work that you're already doing. So when I talk with each of you, we can talk about, you know, the specific good work that you're doing and how AHEAD is going to support that work, not interrupt it. All payer, so I just talked about how important payers are. So Judy has been a really phenomenal partner. And then I bring traditional Medicare to the table. And then tomorrow I have a chance to talk to several of the commercial payers because it really will take all of us. The broader the reach, the more likely that we are to meet the goals that Hawaii will set under the AHEAD model. Health equity, this is still important. And I think that's something that's really important to know, is even if the way that we talk about health equity may change in the next administration, CMS's commitment to ensuring that every person has an opportunity to live a healthy and full life does not change. Approaches and development. So the development part is really where I see our investment in primary care. So that's another hallmark, is really wanting to rebalance our investments in the healthcare system so that we're supporting care that keeps people healthy and in the community. And so the state will be committing on a piece of paper to CMS in writing how they're going to slow the cost growth curve. Because we all know that healthcare costs are unsustainable. We can't continue to grow at this same pace and be able to afford other things that are important to us, like education, roads. And then on primary care investment, again, I talked about this, but just to underscore how foundational that is, and I think Governor Green talked about this morning initiatives that the state's undertaking to really address some of the shortages in workforce. And while we don't have like a workforce program as part of the AHEAD model, we are really seeking to bolster the primary care system with a substantial investment. The equity and population health outcomes are going to be decided by the steering committee, name to be announced. So if you have a really good idea, Jack and Judy are taking any and all recommendations. I had a chance to meet with them yesterday. And again, that reflects a collective voice from consumers, which I call beneficiaries, the provider and payer community, as well as the state officials that are going to be really critical to saying this is what we want Hawaii to achieve over the next decade. Something that's not on this slide that I think is so important is we've been able to give, CMS, states the gift of time. This model runs until 2034, which is incredible when you think about having that type of runway to achieve population health outcomes. Anyone here who works in public health knows that you're not turning that ship in 1 or 2 years. It really takes time, and CMS have given states that gift of time. So the steering committee is going to determine what population health outcomes matter most to the people of Hawaii and what quality targets they want to achieve. And I think there's a real power in writing that down, putting it in black and white, and making that commitment to CMS that this is what we are going to achieve for the people of Hawaii. And so we offer tools because this is an incredibly ambitious project. If it weren't, there would be more than 6 states that signed up for it. And some of this is the grant funding, which is really a modest amount of funding meant to help Jack and Judy and their teams get this program off the ground. So as I mentioned, we're in this planning period right now where they're really working to put all the pieces into place to make the program successful. Hospital global budgets are one tool to align financial incentives. If you think about the way fee-for-service works, if a patient has a diabetic complication and comes into the hospital gets paid. Well, we want to flip that script. So under the AHEAD model, hospitals get to keep revenue that they otherwise would forego if that patient didn't come to the hospital. So if the hospital is doing a great job of keeping people healthy, they're working with primary care to make sure that folks that have ambulatory sensitive conditions stay in the community, that they're working with primary care post-discharge to make sure that that patient doesn't come back to the hospital. Well, then the hospital actually gets to keep that money and reinvest it back into the community. Hospitals want people to be healthy, right? Like, as people, we want you to be healthy. And we have a bottom line because we want acute care to be there when we need it. And we don't know when that'll happen, right? Like, there have been, unfortunately, a number of tragedies in Hawaii, whether that's the wildfires or the fireworks that went off and caused just incredible harm. We want to make sure that excellent care is available when patients need it. And hospital global budgets do that as well. And we also want to ensure that there's access to care in rural areas. I've had an opportunity to talk to several folks who work in hospitals in rural areas, and that's been really helpful to hear what their pain points are and to share where I think the AHEAD model and the hospital global budgets in particular can help them in providing that really high quality care to their community. Primary Care Ahead is what we call the primary care program, where we are offering additional money on top of fee-for-service, and it's available to primary care practices, FQHCs, and RHCs. And that doesn't seem like a big deal, but this is the first time CMS has offered these types of additional payments to rural health clinics. And embedded across this model is a focus on equity, integrating behavioral health, so that'll be a requirement in primary care, engaging all the payers, and so again, thank you to everyone who's taking time to meet with me. Really engaging Medicaid, so we require that Medicaid be a recipient of the grant because they're required to participate in the global budgets. They're required to offer an advanced primary care program. And then again, I'll sort of start where I ended, which is really, we want to accelerate and be a catalyst for great work in Hawaii. So we offer Medicare flexibilities, and that allows for an all-payer approach. Once Hawaii decides that this is the direction that we're moving towards, this is our vision, we're there to support you. And I personally feel really privileged that I get to be part of that transformation. Am I at time? Not yet, but I should move faster. Oh, we're at time? Well, you talked a lot. Okay, well, there's lots of good stuff. There's more good stuff. And there's good stuff. And there's more good stuff. Mahalo.
I'm so sorry. I did talk a lot. I'm really sorry, Kate. I did talk a lot.
No, it's okay, Judy. I forgive you.
So we were wondering if any folks had any questions, either about the head model or, hey, do you like to spend some time talking with Kate, because we're looking to fill up her schedule even more. So
I think I have like 3 hours tomorrow, perhaps,
Yeah.
free. So that's like 6 meetings.
So, or about the waiver, or about palliative care, about unwinding, anything? Anybody have any questions? Yeah.
Hi, Amanda. So, hi, on the waiver, I'm just curious, the justice involved population, which is for reentry, does that apply to conditional release as well?
It applies to people who are actually in the jails and prisons, not necessarily to conditional release. It depends.
Hawaii State Hospital.
It does not apply to Hawaii State Hospital. The federal rules around Hawaii State Hospital are different than what's applied to the prisons. Way in the back? Yes.
Judy, good to see you. Nice to meet you. How should payers begin to brace themselves for changing the new administration? When we look across defense spending, Medicare, financing, state cuts as well, and Medicaid, how should payers prepare themselves for those changes?
Interesting. I was just, I don't know if people could hear, it was like, how can payers prepare for the new administration? And I believe the words pain was in there as well. And, it's like I do have to admit that I have had some sleepless nights and some worries about when I think about, what Congress and the new administration has said that they would like to do, and what they're contemplating when it comes to the Medicaid program in particular. And I've had to come to a place where I can think about what the implications might be and help prepare others for, okay, if you make this change, here's how much money we as a state would lose within the Medicaid program. But I can't control that. I can't control what will happen. So what I am advocating that we do is that we as a state move forward with all the progressive, wonderful things that we have worked really hard to get approval for, and to work to implement them the best way that we can, as quickly as we can, with the same care and compassion. And if we have to have that fight for trying to maintain services, trying to maintain money coming to our state, then we will do that fight together. But let us move forward in implementation to the degree that we can. Yes, yeah. The question, and I don't have any answer, but the question was, but maybe I'm saying this out loud because maybe somebody in the room does know the answer. The question is, there's a point-in-time count for individuals who are homeless. It's done on an annual basis. And she was commenting that it's only going to be done for people who are sheltered homeless, as opposed to unsheltered homeless. And she asked me why, and I didn't know that, and I don't know the answer. I was wondering if anybody does, can you raise your hand, and then we can connect you up. All right. So somebody does know the answer? All right.
I saw Vic pointing me off.
Okay.
Hi, I'm Anna with UH. I do a lot of work with homelessness, and so HUD requires an unsheltered count every 2 years. And so because we did a count last year, we are able to forego that this year. So that's the reason behind taking a year off, so to speak, for the unsheltered account. It also takes a lot of resources. It's very labor intensive. So I think those are some of the reasons behind it. But I will say that there are other data sources that are actually better, I think, than the Point Mind Account that the state can rely on.
Thank you, Anna.
There we have a homelessness services utilization report that's come out. If you find me after, I can put it.
Fantastic, thank you. I love that connection. Anybody else? All right, well, we have a lot of great work to do together. We're so excited, so glad that you're here. Thank you for listening to me talk about all the great work that the team's doing. And thank you for all your help and commitment. Again, we couldn't do what we want to do if you all weren't so inspiring and so committed, et cetera, to the health and well-being of the residents of our state. So thank you.